So the topic of my talk today is best practices using ex-vivo animal brain models in neurosurgical education to assess surgical expertise. My objectives for today's talk is to start with the literature review on what kind of ex-vivo animal brain models are available to train neurosurgery trainees, and then provide a framework, the ex-vivo animal brain model to assess surgical expertise, or EVBMASE, EVB-MASE, to serve as a guide for reporting and analysis of these kind of models. And then I will demonstrate the application of this framework onto the existing literature. Neurosurgery training requires many years of practice and training. Most centers in North America require 6 years. In the US, sometimes 7 years of training. And it's really requiring practicing and gaining the knowledge, the necessary knowledge to manage the neurosurgical diseases, and also to master micro instruments and techniques to perform operations in a safe manner. This type of training worldwide remains dominated by a mentor apprenticeship scenario, where a trainee is following a mentor and trying to learn from him and receive training. But currently there's a wide paradigm shift. In Canada, for example, in our training program, we started to shift to what they call a competency-based training, where now trainees are required to fulfill specific tasks that are defined by the committee. Actually, my junior colleagues are already enrolled in this type of program. So instead of just training for 6 years and then graduate, now they're actually required to provide a proof with each skill that they're competent in. So performing microsurgical technique in a risk-free environment is ideal for especially novel trainees, because I think it was shown in other disciplines where these simulation models tend to enhance or quicken your learning curve. So you reach the expertise level faster. Surgical simulation, what it is, it places the learner in an interactive environment, whether it was a physical environment or a virtual environment, such as those found in virtual simulators. And the goal is to recreate scenarios that we face in the real world, in the OR, and teach defined techniques. Virtual reality simulators have been evolving, especially the last few decades, and currently is used to train surgical gestures in neurosurgery. Our lab has developed the NeuroTouch, which is a virtual reality simulator. In the same time, the value, the biologic tissue gives us value where it has superior visual and haptic realism. That for now it's hard for virtual simulators to really mimic, but it's improving.
Just one thing for the students, you may explain what does haptic mean? They may not be aware of the idea of haptics.
Haptic realism is the feedback you gain from touch, basically. So when you hold an instrument and you operate on this virtual brain or physical brain model, the way the model feels when you perform the surgery, this is the touch feedback. So if you have real biologic tissue, that will be very closely resembling what we feel in the real OR. Whereas with virtual reality, they have to install motors that, with specific equations mimic how much force to counter when you apply on the simulator. And actually, for neurosurgeons, I would say haptic realism is really important, sometimes more important than visual. You really operate with, like, some tumors, really you just have a feel for them when you remove them, and they don't necessarily look that different, but they're really the haptic properties of these tumors give you an idea of the pathology. I hope that's clear. What are the advantages of simulation? Well, I mentioned already, there's no patient safety risk. So you can have unlimited practice time. You have the opportunity to error as much time as you need to until you overcome and improve. It has the potential to give quantitative feedback, which usually in real operating rooms, you don't get that. And this quantitative feedback serves as a teaching tool to teach residents or trainees on how to improve themselves. Whereas in the real OR, that's not available. And also it's less dependent on instructors. You can leave a trainee with a simulator after showing them the basic steps and principles, and they can proceed on their own.
I'll just go back to what quantitative, how do you explain quantitative feedback?
Quantitative feedback would be when you apply what we call metrics, so objective numerical values in a specified domain. For example, in other surgeries, the classic metric was time. So objectively, you can measure the time that the participant takes to finish a procedure. Now, in neurosurgery, that may not be the best metric. That's why we are looking into other types of metrics. For instance, on a virtual simulator, you can measure the force applied on the brain with actual values. You can measure the percentage of tumor removed. So at the end, when you have objective data and numerical values and provide them to the participant, this is what we call quantitative feedback, and it allows the participant to know where they are currently in their stage and how they're going to improve from that point. Now, many brain models are used for training neurosurgery. Human cadavers is an example, although they are very limited in availability and may pose some ethical considerations, but it's available. Animals, whether they're in vivo or ex vivo. In vivo means the animal is alive and they're anesthetized. They require personnel, equipment, and operating room theater. So it's expensive to do, but that's one way of doing that. The advantage of that is that you get the typical brain hemodynamics, brain pulsation, you get bleeding. So a lot of advantages, but it's expensive and not easily accessed. Ex vivo models are about tissue derived from animal cadavers, and this will be my focus for this topic. So extracting brain from an animal cadaver. You can also use synthetic material, and you can use virtual reality for training. So like I said, ex vivo models they're very cheap. It costs $5 to get a calf brain here in Montreal, and they have superior visual and sensory realism. We talked about that, and they're readily very readily, easily available. A big disadvantage is that there's no bleeding, and usually that's something we want to master when we train a neurosurgery resident. Quantitate performance compared to virtual reality, it's more difficult to do so far. For example, in a simulator, like I mentioned, you can measure force because the computer calculates that with the algorithm it has. But on a physical model, it's really hard to measure how much force you're applying on the brain, and this is something that could be a metric for performance. But there are ways around it. On previous models, they use tracking of instrument movement, so that can be used as so it's not impossible, but it's just more difficult and needs more consideration. So my focus is ex vivo brain models, and you can see here an example of that. This is a model by Winkler Schwartz in this McGill's NeuroSim lab. And you can see here, this is the calf brain, and this is the bipolar instrument used for surgery. And this brain was injected with a tumor. You can see this yellow material here. And this serves as a model to replicate a brain tumor removal. You can see how realistic it looks to a good extent what we do in real life. So what is the goal when we develop such models? Well, we want to improve the bimanual psychomotor skills on the simulator. And that's not enough. We need to ensure that when you improve performance on the simulator, that this actually means that you are improving performance in real life. And that's the ultimate goal when we develop such a model. Now, in the literature, there are many models available with different methodologies. The reporting is inconsistent. Therefore, when you try to reproduce such a model, it becomes a challenge. So I will present the literature review done on this topic. From January 2000 to January 15, 2021, a search on Medline using animal brain simulation training and neurosurgery. 1,300 article approximately identified, and we excluded these articles which some of them had non-brain models. So let's say a model that uses chicken wings to provide as a model for training. Live animals were excluded. Again, synthetic models was not our interest. Some of them were review articles. Some of them used human cadavers, and one article had only an abstract. Eventually, we ended up with 18 articles in this review. And when we look at these 18 articles, it seems like there is 3 ways we can categorize them. Sorry. So one way is that these models have been modified to recreate human pathology. I've showed this earlier. So in this example, this would be a brain tumor. So there are 6 models that recreate pathology and provide this as a model to remove a brain tumor. Other models did not modify the brain at all, which is the one you see here on the right. So they're just a pure anatomical mimic of what a human brain looks like. And they are used for dissection and handling of instruments. The third group is related to the second group. They're also non-modified, but they are task-based. So they allow for certain procedures. As an example here, this is an ultrasound machine used on the brain, which we do commonly in the operating room. And you can see here the task is to identify a cyst. So this black circle is a cyst that's been put inside the brain, and the task was to identify it. The most common species used were the bovine brain, around, so 8 times, 47% of the models used bovine brain. And the bovine brain is the largest of these 3 animals. They weigh approximately 500 grams, which is just under half what the human brain weighs. Whereas the ovine and the porcine models are much smaller, weighing somewhere 120 to 150 grams, and they've been used less commonly in the review. So talking about the models that have been modified to recreate pathology, these were 6 out of the 18, so about a third of them. And some of them focused on having properties similar to real tumors. And I will show how that was done. They have the advantage of creating comprehensive research platforms. And what I mean by that is in a real setting, when we operate on patients, we have imaging before doing the surgery where we can assess the tumor, where it's located. Then we actually do the surgery, and then we evaluate the surgery by doing post-operative imaging. So the models which are modified to this definition have the ability to apply all these 3 components, and therefore it can be used for performance quantitation. You can also incorporate gadolinium within these tumors, and this allows for the imaging, because gadolinium is a substance that the MRI picks up and can identify easily. And also it has the ability to incorporate fluorescence dyes. These are dyes, I will show a picture later, that can be used to monitor your progress in the OR, because some tumors fluoresce with these dyes. So you can put the ultraviolet light and you can see that, oh yeah, there is still some tumor left. So you can judge how much tumor you removed. These are the 6 models of which were modified. The last 2 models here were developed in our sim lab. And you can see that they're the ones that have gadolinium and have the ability to incorporate it into imaging and MRI quantification. In terms of assessing whether the properties of the tumor is realistic, what Alex did is he took actual tumors from real patients and then measured the force properties of these tumors, which translated into kilopascal values. And then when developing an artificial tumor, he took into account to replicate those results, therefore mimicking the consistency or the haptic feel of what a real brain tumor feels like. Another author, Valley et al., they use different mixtures. What they used in their study was aspic powder and gelatin. You can see here there's about, I think 12, many different combinations of how much grams of aspic powder, how much grams of gelatin. And then they gave those different preparations to expert neurosurgeons. And then the neurosurgeons were asked to evaluate them on a Likert scale. And then they chose the model that had the highest rank, which is this one on the left. So these are examples of how the focus on realism can be translated into model development. And this is the advantage when you actually create pathology and modify the brain. This is from Dan's paper. Last week he presented, for those of you who were there last week, the ability to quantitate how much tumor was removed. So you can see here in white, That's the tumor. This is an MR scan, and it's white because, as I said, the tumor was infused with gadolinium. So after the surgery, you do an MRI again, and then you can measure how much exactly was removed. And not only that, you can also measure how much of the normal brain was removed, which is important. Uh, Ideally, you want to remove only the tumor, and you want to minimize the amount of brain removed. And this is an example of the article from Valley et al. They tried 5 different fluorescence dyes, and you can see here how they glow when specific light filters are applied. And it gives you a guide to how much progress is happening in your surgery. So these models provide an opportunity for assessment. You can quantitate technical skills and potentially be used for formative and summative assessments of neurosurgery trainees. Now we're moving to the next set of models, which are non-modified. These were 8 out of 18 studies, around 44%. And really what they offered is just dissection opportunities. So you would get the brain and you would, train with your instruments, different approaches we commonly do, the Sylvian Fisher approach, the interhemispheric approach, the posterior fossa approaches where you have the cranial nerves and their foramina and the skull. But these models don't really provide you with the quantitation of your performance. They're just a replica of anatomy. These are the 8 articles, as I mentioned, and yeah, most of them train only gestures and dissection. The other subgroup of the non-modified brains are when they're task-oriented or allow the performance of procedures that neurosurgeons commonly do. There were 4 articles out of the 18, and the tasks that were trained were cranioplasty and fronto-orbital advancement. When you reshape the bone, the skull, and the other one is ICP monitor insertion. This is a basic skill required by neurosurgeons, where you insert a transducer into the brain to measure the ICP. The third procedure was suturing of the dura mater. And lastly, which I think I showed a picture, is the intraoperative ultrasound, where they would give the participant the chance to identify certain anatomical areas of the brain and to identify certain structures in the brain.
Ahmad, can you just discuss ICP and just dura for some of the individuals on the call?
Yeah, sure. So intracranial pressure is a way to know what the brain is facing in terms of pressure. In certain populations, normally you have some sort of intracranial pressure, somewhere between 5 and 15 millimeter of mercuries. And in certain patients, like trauma patients, you want to know exactly what their intracranial pressure is, because that can influence your decision to operate on them or give them certain medication to lower that pressure. Because when the intracranial pressure goes up from a specific pathology, it can lead to herniation and death. So you don't want that. Yeah. So this is a very important skill, and it's trained in one of the models here. These are the 4 references for the 4 task-based models. So what combines these two subgroups of non-modified brain models. They didn't pay attention to validation, and there was no real quantitation of performance because there's nothing to quantitate. You're not removing a pathology, and these lead to limited reproducibility and usefulness when you want to assess trainees. They might have some role initially for junior residents, just to have maybe a feel or what like handling of instrument, but this should be very brief, and it really provides no value for feedback on an objective assessment. This is a paper published by Alexander, former PhD student in our lab. And what he did was used best practices criteria. He looked at virtual reality simulation papers and how was machine learning used to assess surgical expertise in a virtual reality setting. And he came up with 20 different points where an ideal machine learning virtual reality simulator expertise checklist would consist of. And this led to something similar with the ex-vivo brain models. So the same thing is to provide a checklist where an ideal ex-vivo animal brain model would consist of. So the objective of this checklist is to help researchers improve the ex-vivo animal brain models when they do their studies, provide reviewers, journal reviewers to a methodology to assess the quality and the deficiencies of the paper describing the model, and to also apply this checklist to the articles published talking about brain models, ex-vivo animal brain models, and to document how current brain models are used to train surgical expertise. So it's a framework that helps standardize the way we deal with ex-vivo animal brain models. So again, it's all about what is the ideal model. We identified 20 key components over 3 dimensions. The first dimension being the study design of the model. The second would be the data structure. And the third would be the discussion of that model. These are the 10 points in the simulation study design. I will go through each one of them quickly. So whether the authors of that specific model provided literature review or not, there should be an attempt to look at ex-vivo animal brain models in the context of previous models. Like I mentioned, an ideal model would comprise a comprehensive research platform where you have a preoperative assessment, the resulting operation, and then a post-operative assessment. So an ideal model would consist of all of 3 of those components. How realistic was the model? So did the model use a skull replica? Was the model properly draped, like what we do in a surgical setting? Were the instruments used appropriate? And was there a microscope used, very much like what we do in real surgery? Then they should describe the model in terms of which animal brain was used. If there was an attempt to simulate a certain pathology, then there should be good documentation of how this model was developed and what are the properties that simulate the human pathology. Next is talking about validity. Was there an attempt to validate that model or not? These are 5 forms of validity, and I always get mixed up between them. So I ended up briefly putting a question and what it means in terms of validity. So when we ask the question, do these models appear to reflect the human operative experience? That's when we're talking about face validity. What is the value of teaching of the skills in this model? That would be the content validity. When we ask, can these models reliably distinguish an expert performer versus a novice or a beginner performer? If it can do that, and then that's construct validity. How effective the model outcomes correlate to the gold standard in assessing that specific procedure, that's concurrent. And the last one is this model achieving the goal of improving outcome or improving performance in real surgery? And that's the ultimate goal. That's the predictive validity. Simulated task description. Again, the task that's being done should be described. What was the assessment tool utilized? For example, if there was an, like what Sharif is working on, EEG, for example, whether there was instrument tracking, infrared cameras. So there should be an attempt to have an assessment tool. And then to define what an expert is in that procedure and what other less skilled people and how are they defined. So those were the 10 points regarding the study design. Next comes the data structure. And these are 5 points as I show here. Where are the metrics used as assessment tools defined? Now, like I mentioned, a lot of the models that were demonstrated in the non-modified brain type, they did not have a metric. So this is not ideal, and it decreases the educational value of that model, because if you can't assess someone, then you can't teach them to improve. Then if there were metrics chosen, were the purpose of each metric outlined? Were these metrics validated to show superior performance, for example? And then talking about sample size and the statistics used in that model. And lastly, were the sensitivity and specificity of that model mentioned? Next is a discussion, 5 points as well. Is the educational application of the model in the context of simulation outlined? Were efforts made to explain what was the educational value or the educational rationale of the simulation model used? For example, if a certain metric defines or was validated in terms of construct validity, then can this metric be used to teach participants to change from a novice to an expert? So that would be the value of education in that model. Is the role of this model discussed as being used in formative and summative assessment? Of course, if there's any limitation, it should be discussed. And the future directions and the improvement of the model, were they discussed or not? So when applying these criteria to the aforementioned articles, you can see if you take all of the modified and non-modified brain groups together, you get an overall score of 6.7. That's the mean score. And in percentage, that's 33%, because the total score is from 20. The data structure and discussion are very poor. And I think that's mainly influenced by the non-modified brain groups. And this is the results showing the different type of models in correlation to the checklist. So you can see clearly that the modified models have an overall increased score. They have improved study design, improved data structure, and improved discussion. And overall, the mean percentage was 54%. When looking at the non-modified brain models, when it seems that when you have a task or a procedure specified, you have a higher score according to this platform. So the mean in this group was 6.25, 31% percentage, which is higher than that in the pure dissection models or non-modified models. So the next step would be the scoring of this best practices checklist by another author to allow for descriptive statistics. I want to look of how applicable this checklist is, what's the inter-rater reliability, since this is a novel checklist. And in terms of discussion, this checklist will have the potential to improve the quality of future papers talking about ex vivo animal brain models to train neurosurgeons. And like I mentioned, it was clear that the modified models had an advantage in defining the metrics to assess performance. They were more comprehensive. They simulated operative realism superiorly, and they tend to have a more precise definition of expertise and an educational application due to the fact that there is a defined metric that could be improved. The non-modified models tend to score higher if they were task-oriented, like I mentioned, and they can serve as a guide for reviewers and journal editors to ensure the best practices are applied to ex vivo models. And also this checklist will improve the standardization of these models and how well they're reproduced within the neurosurgical community and people interested in surgical education. Thank you.